All right, everyone, we'll go ahead and get started. Great crowd we got here today. Proud of you guys for coming. Today we have a great talk by Dr. Christopher Fan. We were just talking about his numerous degrees. He has 3 master's degrees, very impressive. A master's in social work, an MBA, and an MPH. Very impressive guy. So we're thrilled to have him today. So we'll let you take it away.
Awesome. Can people hear me? Awesome. Thank you. So, I got to figure out where I can stand where all the other microphones don't catch me as well. Well, good morning, everyone. Thank you so much for the introduction. My name is Christopher Fan. I use he, him pronouns, and I am proud to be here today to kind of just present to you kind of the idea of what diversity, equity, inclusion, and belonging looks like on the BJC side. I know all of you straddle both the Washington University side and Barnes-Jewish Hospital, St. Louis Children's, and BJC HealthCare as a whole. And I'm just really excited to kind of present some information, but really I kind of want this to be somewhat interactive because one of the things that I detested the most throughout my education was when I sat there and was told everything and I had to try to keep my eyes open for 1 hour on things that I kind of already knew, but just didn't feel like I had the opportunity to be part of that conversation. I'm not sure how long I'm supposed to keep this up, but I'll just see if everyone gives me a show of a thumbs up that you read this and you attested that this was here. Great. I also apologize that I tend to pace, so this is not going to be the greatest thing for me to keep having to run to the keyboard. As you can tell on the slide, that is not me. That is my leader, Dr. Stephen Player. He is the BJC Vice President of Diversity, Equity, Inclusion. He told me to change the things out, but I said, you know what, I actually want to keep you there because I want people to understand that the leader of our Diversity, Equity, Inclusion team is in fact started off in the clinical realm, had great passions towards what he did on the clinical side for patients, ultimately wanted to move over to try to affect patient health outcomes in a greater and different way. But also the fact that BJC HealthCare is in a position where they are proud to actually have a vice president of DEI over all of BJC. These are the things we will cover. I'll give you a chance to read them. I don't like reading my slides because I know you have all gotten through med school and you are in your residencies and fellowships, so I understand that you can read. All right, quick show of hands. How many of you have heard the terms diversity, equity, inclusion, and maybe even belonging? Just, you've heard the terms. You've probably heard the terms a lot in med school. You've probably heard the terms a lot even during your time here at Washington University and at Barnes-Jewish Hospital. What my guess is that these are the kind of definitions they gave you of what diversity, equity, inclusion, and belonging are probably defined as, right? They're quite wordy. They're quite academic sounding, right? So we talk about diversity as all the aspects of human differences, including, but not limited to, all these characteristics. We talk about equity, about fair opportunities, inclusion as kind of this attainment of a lot of things, and then belonging as a feeling, right? So those are all the general pieces. At BJC HealthCare, one of the things that we are trying to think about is how do we reduce the level of kind of the academic explanations of things and really getting back to what does this actually mean when it comes to how do you interact with people in front of you? Because one of the hardest things that we face in diversity, equity, inclusion, and belonging work is that it makes it sound like you have to be really, really intelligent to understand the concepts of how you do this work, and you don't. I always like to joke around that diversity, equity, inclusion work is simply how you become a human to other humans. And I will honestly say we have spent a long time of our lived experiences being taught how not to be good humans to all humans we encounter. I'm not saying that's always intentional, but sometimes unintentionally, we have been trained how to not always be the best human in front of others. So what we did alongside our partners at the Missouri Hospital Association is we kind of made a much simpler version of how we talk about diversity, equity, inclusion, belonging. The spirit is exactly the same, but we wanted to make sure it was a way that it was more approachable by the people around us. So if you think about it, the idea of diversity is just simply the unique identities that make each person up. So if you've ever been asked the question, how many of you think you're a diverse person? Usually what happens, I'll be very candid, usually what happens is most white men don't raise their hands. About half of white women will raise their hands, and about anyone else who identifies as a person of color will raise their hands. And what we're really trying to ask people to think about is everyone is diverse, because you all carry a lot of experiences and a lot of identities that are unique to you. And what you bring is something different than the people around you. So for example, Dr. Horn was telling me how she is from Kentucky, right? Regional diversity. You know, one of the things that I'm sure WashU prides itself on is trying to attract the best from across the United States and from across the world. That level of geographic difference is something to be celebrated. Similar just how we talk about race. Race is one of those easy ones that we talk about. But what I can also want to ask, is there anyone who may be first generation medicine, right? You're the first person in your family to pursue a medical degree, right? That's diversity, right? Because many of you, you did not go in with this idea that people were training you to like, this is what a doctor is and this is what a doctor is not. So that's diversity as well. Anyone bilingual, multilingual, speak many languages, whether you like it or not, great. That's also a form of diversity. So what I want you to think about is when you hear the term diversity is that you are a diverse person. And the way you think is also incredibly valued. The other piece that people don't talk about in diversity is that it's within a shared space. So if you talk about diversity, you just say, hey, diversity is just all the differences we have, and you don't localize it to where you are, then that's the part where I think a lot of people kind of, where we think we kind of do the work in a way that may not always be in a way that can meet people where they are. I'll give you an example. One of the big things, and we'll get to that slide in a little bit, one of the big things we talk about is how you diversify leadership representation. Right? How do you make sure that the people who are in leadership positions kind of represent the people who are trying to obtain positions, as well as the people that we are taking care of? Well, if you're in a small rural area and you set a goal for 25% people of color for your leadership, that might be slightly disingenuous to that region. Right? So the idea of diversity is not always how do you spread across an entire region saying we need the same numbers across the board, right? That's the idea of the quota system of diversity. It is how do you ensure that representation matters across people, and how do we make sure that there's an honest conversation over how do you do this work? What does diversity look like for a region, and how do you increase that level of diversity as that region itself is also growing and becoming different? I'm not saying that you shouldn't go for certain things, but it's also, you can imagine how much harder it would be to maybe going to a very, very small town in Nebraska and trying to set a timetable of how many people of color, right, as a very distinct form of diversity as your goal for representation, as opposed to saying what other identities within diversity can we work on to diversify where we start, right? It's always starting points. When we think about equity and inclusion, going back to the same idea, are we providing fair opportunity? We are not saying equal outcomes. I'm sure I am not talking to a group of people who don't understand the idea that like we cannot guarantee equal outcomes. We can do our best to ensure that there's fair and equal opportunity. So I want you to think about like, do all of our patients have fair and equal opportunity to have the best health outcome that they want and desire? The answer is probably mixed, depending on what examples we would give. But that's the idea. That's the one thing I want to always want to dispel, is this idea of when we talk about equity and inclusion is that the outcome is the same. It is not. We are one of the things in healthcare that we would like to really get people to understand is that you do not own the outcome. You own everything else up to it. The opportunities we provide, the information we provide, the amount of effort we put in, the outcome will always be something that we cannot control. And oftentimes, and this is from my social work background, oftentimes that is ultimately up to the choice of the patient and their family to decide what their outcome will be. And I know sometimes I have a few friends who are physicians, and I know that is the one thing that frustrates them the most sometimes, is at the end of the day, patient decides. Patient makes that choice. And then finally, belonging. It's your sense of how you feel about where you are. So we could do all the first three really well. We could say that we're a very diverse group. We're providing equitable opportunities. We're trying to create this idea of inclusion. But if that person or you do not feel like you actually belong here, and that you can make meaningful contributions, then that's still a disconnect. And I'm sure there are many of you who've had that feeling before everywhere you've been, where there's this weird mismatch of who you are and the place you are, and you just don't feel like you can be fully your authentic self, and you can contribute all the way through. All right, this is first participatory group moment. Anyone want to just be brave and tell me a time where one of your identities has either made you feel like you were part of a group from an equity, inclusion, or belonging standpoint, or that you felt like your identity may have created that gap? Anyone want to just share a single time? I can also outweigh all of you. Yes, thank you. Absolutely. Absolutely. I won't pretend to try to assume the feelings of that. My guess, though, is that being the only or the lone person doesn't feel great. Whether it's from they all look to you to speak on behalf of a grouping of human beings, or you just feel like there's a weird power dynamic that is just different, right? That's very real. We know that is very real in healthcare. Lots of research studies have been done around power across gender identities in healthcare. Anyone else? Yeah, absolutely. Mm-hmm. Mm-hmm. Yeah. Yeah. Yeah, absolutely. Thank you for sharing that. And one of the things that is always very real is that our identities don't always come with the same level of, I would say, comfort that maybe it has afforded us in different times, right? So depending on the place and space we are in, we may feel more or less included or that sense of belonging immediately. That's very real. Thank you so much for sharing that. How about patients? Maybe you're willing to speak on behalf of some of the patients you've seen. Has anyone ever noticed that some of your patient populations may feel like their levels of equity or inclusion or belonging is different when they come onto this campus for care? So no, you think all of our patients feel a tremendous sense of belonging every time they're here? Yeah, Dr. Brown. Mm-hmm. Yeah, absolutely. That is one of those real things that I also have heard from a lot of physician partners about the moment where a patient says, I've never had someone who looked like me take care of me. And that means something. I would also push that towards, so one of my primary responsibilities across BJC is ensuring accessibility across language, across all of our hospitals. So you can imagine what it's like for a refugee or immigrant in St. Louis to hear their language spoken to them by a provider or by anyone who's not an interpreter, right? That means something to them. So the idea that we have individuals or community groups who are looking for a sense of validation, a sense that they are welcome to a group is very big. So thank you so much for sharing that. And then speaking of LGBTQIA, right now it's a very tough time for people to feel like they belong, especially in this state. I'm not going to get political. I'm just going to give a basic reality that when you legislate against just an identity, which is factually what happened, you legislate against an identity, the level of safety, the level of inclusion, the level of belonging will drastically suffer in that realm. So We're going to go through this one pretty quickly. I am sure many of you are aware of this, but this is really just a slide talking about the social determinants of health. So basically the 95 to 98% of everything else that actually affects someone's health and possible health outcomes that has nothing to do with inside the four walls of a hospital or a clinical space. So we talk about neighborhood and built environment, social and community contexts, economic stability, healthcare, and education access and quality. How many of you know this is very real? Anyone want to share an example underneath the neighborhood and built environment on how that can actually affect optimal health and the physical, mental, social well-being aspect of your patients? How does the built environment affect that? Was that a hand? Yeah. Mm-hmm. Yeah. Yeah, absolutely. One of the real critical pieces is when we're trying, especially in the world of weight loss or health, you're trying to get people to exercise more. A lot of people just where they live would very much prevent them to be more active, right? Because then you think about kind of Maslow's hierarchy of needs of like, well, my doctor told me I should exercise more, but my safety is kind of more important than getting a 10,000 steps in today. Thank you. Anyone else? How the built environment contrasts? Yeah. Mm-hmm. Yeah. Yeah. Absolutely, right? The best medicines in the world, highly economically prohibitive to a lot of patients, especially the patients you probably see, right? And then all of a sudden you have to try to go back to what are the other medicines and what are the cocktails you can kind of put together that can make that original one that you would love to give someone that. Yeah, so economic stability is a very, very big one. Has anyone run into transportation yet as one of the things that you face with your patients where you saw them one time, they seem really, really wanting to be healthy, stay healthy, do the right work, and you don't see them for like 6 months. And then they show up again, you're like, what happened? And they're like, either the person who was supposed to give me rides all the time flaked out on me, or the bus route changed and I wasn't going to get on 6 buses to get here, all those things. How many of you have any experience with that? Would you like to share just really quickly kind of an experience? Mm-hmm. Yeah, absolutely. Thank you. Anyone want to take a guess at the social and community contexts that could affect someone's health and health outcome? I'm not going to let Dr. Ross speak on that. He'll know too many answers. How do you think the role of community can affect a patient's health outcome? Or social? Go for it. Mm-hmm. Yeah, absolutely. Absolutely. One of the real things about healthcare, if you haven't been taught this enough, is healthcare has a really bad history. Eugenics was started in the United States. It was a real actual discipline that people got to study, right? We actually had like departments of eugenics at schools. So you can imagine for many people, their families and their generations before them, what they were taught about healthcare their entire lives. That you are simply a test subject, you will get worse care. And people were able to back that up with a lot of real stories. I am not sure how many of you have gone through kind of Aaron Stamp, Dr. Pittman, and kind of the WashU DEI curriculum. They do a fantastic job kind of walking you through some of the history. But WashU and BJC, we were segregated for quite a long time. Even beyond when we were supposed to desegregate our hospitals, we stayed segregated for quite a long time. And the stories of Black women giving birth in a basement, true. The fact that you had to walk by the morgue to get to that spot, true. The fact that certain Black individuals were placed in the coldest parts of the hospital, true. Right, so those are real stories, and you can imagine that only happened like 1.5 generations ago. So there are people alive today who say, this is my mom's experience. This is my grandmother's experience. So then you can imagine the level of trust that comes with it and the level of trauma and harm that comes in with that, right? Because not only is it a history for people, but it's also an experience that person now is gonna look in front of you and say, you need to prove to me why I should even trust you. So it's already a level of, we're not on a level footing together. LGBTQ is the same way. Right, I think that many LGBTQ people could say that probably their healthcare hadn't turned around, maybe except for like 7 to 10 years ago. So you can imagine they've only had 7 to 10 years of like maybe the idea that healthcare was going to take care of them in a broader sense. And now you have legislation saying that we're no longer doing that. So you can imagine this long harm and trauma of distrust. The other part of community and social context I want you to think about is depending on how you were raised, you have different ways of how you do healthcare and how you do medicine. I come from a family that trusts Eastern medicine just as much as Western medicine, but we don't call it medicine. We just call it living life, right? There's tonics and things that you make and drink and do that are supposed to keep you healthy, and we would never disclose that to a doctor because they would say, what are the medications that you're taking? That's not a medication to my family. Or if I have a physician telling me I need to do this every day, I'd be like, nah, I gotta do something else. And then we'll get into an argument over that. The other part, and this is where in social work, I've seen this a lot, and I don't know if you see this on your side, is simply power dynamics in communities are very different. Sometimes the physician is not the most powerful decider of someone's choice. In many Western cultures, I will just say this, in many Western cultures, for me growing up in upstate New York around predominantly white communities, whatever your doctor said, you did. There wasn't really like a conversation with other people. Maybe you had it with your partner, and then like you just agreed and you did what the doctor said. I grew up in a family where there's more people you call to walk through the questions you were given, and then as a collective, you may make a decision together, right? So my doctor said I should take this medication, and then you kind of call some uncles and some aunties, and they kind of like walk through their experience with that same medication, and then eventually you decide like whether you take the medication or not. So I just want you to think about all these contexts really show up in the physical, mental, social well-being. And then easily, healthcare and education access. We know that the less educated you are, the harder it is for you to maintain a healthy life and a healthy outcome, right? Because a lot of it then comes to economic stability, where you can be relative in the built environment and the kind of context you are involved. And then healthcare, very real. Healthcare access is one of the biggest things that we are faced with every day, that there are unintentional and intentional barriers that have been set up that basically prevent people from accessing the kind of care that they need. So some examples that you can easily think about is, how do you think someone's health outcome, and these are St. Louis examples. How do you think someone's health outcome is going to look when they, as they age, if they go to a school that's unaccredited, which means that perhaps a university or college will not accept their high school diploma, or that they grew up in a neighborhood exposed to an excessive amount of air pollution. But let's just say toxic anything, because that's kind of the story of St. Louis as well, is that it doesn't have to be air pollution. It could be many other things. But we do know that air pollution was a huge thing in St. Louis, and we have one of the highest rates of asthma relative to our size. And then finally, living in a community with limited employment opportunities, right? So as manufacturing jobs kind of left the entire Midwest, what do you do to a group of thousands of people who were trained to work in a GM factory, a Ford factory, a Chevy factory, and you take that all away from them? There's really not much, all right? Or the story of Homer G. Phillips. You have an entire hospital system built on the economy of one area, right? Not just how you employ hundreds of people in a hospital, but then you have the employment of entrepreneurs around who are saying, I'm a restaurateur, I am going to do all the things that support families that work at a hospital, and all of a sudden that's shuttered, and an entire region gets, basically their entire livelihoods get taken away from them. Those are those kinds of things that St. Louis got to witness and got to experience. And something that we do at BJC, if you are so interested, is we do a virtual health equity tour. I know that Dr. Ross has done many of the physical health equity tours, but we just want to expose and to have people experience kind of what is that lived experience across St. Louis. All right, so we are so I'm just gonna give you a very quick landscape of where we are in. None of this should be a surprise. None of this should be a surprise. There's a lot of challenges in healthcare. I'm not even gonna make that as a question, there is. We're a highly regulated system, which is becoming more and more regulated, but not just from regulators, right? We're becoming regulated by legislation. From a state level, from a local level, from a national level, that you are now not just facing regulatory pieces that are trying to create patient safety or patient outcomes, but now we are still being faced with legislative and judicial decisions that are then going to shape and reshape how we can do healthcare. Agree, disagree? And so, as you see up here, these are some of the things that we know are kind of the focus of how we are going to try to meet this landscape, right? There are financial challenges. I'm sure all of you are very aware there's financial challenges across healthcare. And I don't mean just the bottom line for a healthcare institution, but also stagnant compensation across the board for people who work inside healthcare, right? It's a very hard situation to be in where healthcare systems are trying to meet budgetary concerns and constraints while also understanding that there's a compensation concern across many people. Once again, not political, just saying that that's a landscape that we face every day. Workforce shortages, we know that COVID exacerbated the amount of people who decided that healthcare was no longer for them, whether it was early retirements, whether it was just the risk of being in healthcare, or simply burning out. I'm sure some of you may have friends or colleagues or family members who are like, I'm done with healthcare now. Or I need to take a break, and they chose to leave. And then what you also see is that from an education standpoint, we couldn't, and we still cannot kind of meet that gap as fast as we'd like to. Access to care, I'm sure all of you want to all be internists and primary medicine people because you are going to help us meet that. No, I'm joking. I don't expect all of you to do that, but that is one of those big things, right? Especially in rural areas. Anyone from a rural town or a rural area in the United States, and you see that, like, what is now the new radius of driving to find a primary care physician? And then on top of that, how many more miles of radius do you have to drive to find a specialist, right? So you can understand what that health outcome looks like for people. And then finally, equitable access to healthcare. We can talk about this until I'm blue in the face around health disparities and unequal treatments. So one of the things that BJC and our partners at WashU, we do every day is we challenge kind of the landscape of that through three things: research, regulatory, and realities, right? The research part is all the best emerging practices that I know many of you are a part of. I know Dr. Baranski, you've done a lot of work in the Transgender Center, right? So trying to, what is the research showing us on what is the best way to do some of this? What is the emerging ways that we should do this, right? Whether or not we fall flat on our face a couple of times, hey, that's part of medicine. That is part of doing best medicine for people, is to take those chances and to see what the emerging practices look like. We also know from a regulatory standpoint, right? So across the board, we see regulatory bodies pushing the envelope, saying, we understand what the legislative environment looks like, but we also know what's best for patients. So how do we do this? And how do we follow through with that? And how do we pick and say, from a regulatory standpoint, the Human Rights Campaign may not be a regulatory body, but they're putting out expectations for us, and we're going to try to meet them because we know what's best for patients that we seek. But then we also know that the realities, right? The Supreme Court bans affirmative action. The Supreme Court bans a few things. The Supreme Court makes certain decisions, and all of a sudden that sets a new expectation on how we do this work. So I just want you to understand that meeting these challenges is you're not alone. I know that for many of you, you're on the front lines. It feels like you are absolutely alone and that the whole system's against you. We are doing our best not to have that feel like that. We are really trying to understand how does the research help us? How does the regulatory pieces help us? And how does the reality we see in front of us, how do we have the opportunities to find the reality that we can walk to together, right? Because one of the things, if you want to focus on the negatives will keep showing up. You focus on opportunities, at least we can find ways and innovative ways to say, let's try something different. And I will say one of the great things about BJC and the partnership with WashU is watching a lot of WashU people try to be innovative every day and trying to push that envelope for us. So on the BJC side, we follow this simple roadmap. That is from the American Hospital Association's Institute. Oh man, I used to know this off the top of my head. Institute 4, I think. I know the last one is health equity is the last two. I think it's diversity and health equity. But it's the Institute, and then the F I don't think is 4, because usually you don't acronym the F. I will let you know in a second. It'll come to me. But focusing on culturally appropriate patient care, equitable, inclusive organizational policies, collection use of data to drive action, diverse representation, community collaboration, systemic and shared accountability. I'm not going to talk about these slides too much. I just want you to know that BJC, when it comes to from a DEI lens, we want to make sure that everything we do, DEI is part of how we do it. That it's not an added piece. It is just simply, this is the only way we can do this work. You want to be a healthcare leader? Well, you better do it from a diverse, equitable, and inclusive standpoint. You're not a healthcare leader if you do it for one group of people, and then your mission is slightly conditional. In the idea of, we give world-class medicine to those as long as you are not. Right? We don't profess to that. And then our purpose is to make sure that all of our programs, practices, people, and policies are scrutinized with a diversity, equity, and inclusion lens. I'm just going really quick through how our how our department is currently structured. We have 3 work streams. You do have access to all of these. Workforce diversity, this is where we really think about how do we have those pathways. One of the things that we've been very proud of, and I'll give an asterisk next to it, is that from a representative leader standpoint, we are doing very well relative to the landscape on kind of diversifying what our leadership group looks like from a director level and above across BJC. The asterisk part is that most of those are recruited from outside of our own teams. So one of the things that we are trying to push is, how do you actually have people who are of BJC become directors and above, who identify as a diverse person, right? And so when we talk about diversity, one of the things we've looked at right now is race, right? That's one of the easiest ones we can collect data on. But right now, what we're also thinking about is, what does that look like from a standpoint of the other parts of diversity? Are we looking at neurodiversity when we talk about people who are being internally promoted? Are we talking about people who are from different educational backgrounds, people who are from different lived experience backgrounds, and things like that? DEI consultation, most of you are probably very aware. At a time, DEI has been known as like the training and education 911 reactive trainers who call everyone racist and tell you not to be racist anymore. We don't do that anymore at BJC. One of the things that we're really trying to do is, how do you consult with leaders? Because at the end of the day, are the ones who set culture in their groups. They're the ones who ultimately are responsible and accountable for the growth of their people. So how do we make sure that we are actually supporting our leaders and saying that where it's hard, we're going to work with you. We don't want you to feel like you are alone in doing this, but how do we help you be able to feel confident in how you are growing the people around you, and that you feel comfortable and confident doing that for yourself as well. What we don't want to do, and we still continually don't want to do, is do the thing where someone's like, hey, I think I heard someone say something racist. Can you come in with a 15-minute training to tell people on how not to be racist? It's like, yeah, well, we can't. Because racism has been taught for hundreds of years. You can't un-racist someone in 15 minutes. What we can do, though, is we can walk through with your leadership team on understanding what are the techniques on how you create connection with each other? How do you create those skills of being able to have people have conversation with each other and be able to unpack certain things? And then ultimately, on the other side, how do we work with our hospitals on making sure that our practices and our policies are actually accountable to what we do? Right. So one of the things that our chief people officer likes to have us think about is, you either grow people or you ask them to leave. Because one of the things that our mission asks us to do is that if you're not aligned with our mission, you don't necessarily have to be part of BJC HealthCare. There are plenty of other institutions here that would be more than happy to have you. And so, one of the things that we're trying to be very serious on is the level of culture and the level of expectation we have. Dr. Brown, you asked earlier before we started about kind of Deidre's side and Stephen's side of how we do this work ultimately. And this is how we do it at BJC HealthCare. So we don't have one single department who focuses on health equity or patient outcomes or just diversity, equity, inclusion as a whole. We have 3 different departments that kind of create this Stephen calls it the 3-star constellation. You think of Orion's belt of how we do this work. So we have community health improvement that is led by Deidre Griffin. And what they focus on is what is our relationship with the outside community? So how do we pour millions of our dollars into Black-owned banks to keep them secure? But also because we're a huge financial institution, we have to invest our money somewhere and we have to hold our money somewhere. So can we make those reasonable things? Can we focus on certain zip codes? How do we do health outside of our 4 walls? How do we also empower community groups like doulas to be part of the conversation of what it means to have a good health outcome, especially for Black women giving birth? We also have our team, the Diversity, Equity, and Inclusion team. We're more of an internal focused group. We think a lot about how our policies, programs, and practices are actually leading us to being able to actually not just cultivate, but recruit and retain the best talent, and then also become that employer and provider of choice. And then finally, Dr. Hillary Babcock oversees kind of our healthcare equity and care delivery. So that's looking at all of our data. What do our patient outcomes look like across race, across gender, and across numerous pieces that we can cut? Really quick, I'm not going to focus on this too much because I think the slides are shared with you. These are our 6 priorities at BJC for diversity, equity, and inclusion. You wanted to ask us, what have we done in the past couple of years doing that? Here's just a list of certain things that you can or don't have to be super proud of with us. But some of you were here when these happened. So I would like you to celebrate as part of the BJC team as what you got to be a part of, especially those who are always at BJH and St. Louis Children's Hospital. Thank you for all of your work on the physician side of ensuring that still to this day, for the past 6 or 7 years, those 2 hospitals are the only 2 hospitals in a 220-mile radius designated by the Human Rights Campaign as a healthcare leader in equality for LGBTQ people, right? And you can imagine what that means for this region and for anyone who cannot get to Chicago and sit on that wait list in Chicago for LGBTQ care. The other one I want to focus a little bit on is kind of the language access piece. Show of hands, how many of you have already worked with someone whose preferred language is not English? All right. How many of you are really excited when that happens? Great. Hey, I get it. I hear it every day. This is what you face every day at BJC. This is what we did in 2022. This is what you did in 2022. 124 languages across BJC HealthCare. 100 of them at Barnes-Jewish Hospital, 85 of them at St. Louis Children's Hospital. So if you think about, and most of them go through our clinics. So for all of you who love clinics, that's you. You get to see many of them. This is the top 15 languages across BJC. Most of this is affected by Barnes-Jewish Hospital because of the amount of people who use the clinics at Barnes-Jewish Hospital. One of the things I want to just have you all understand is Pashto, which is one of the primary languages from Afghanistan. That is skyrocketing across our region because more than 700 families have come in the past 2 years through the International Institute as refugees because the mayor of St. Louis City and the county executive of St. Louis County opened the doors of St. Louis and said they are welcome here. So I will tell you that we do have a full-time Pashto interpreter on staff at Barnes-Jewish Hospital and that we made sure that we do have that language ability for that. One of the other things I do want to raise to you, if any of you have ever faced this, has anyone faced the Mayan languages yet? in southern Mexico, Honduras, Guatemala, Nicaragua, right? The ones where you're like, the person should be speaking Spanish and it's not Spanish. Yeah, it's Quiche or some of those other languages. We have just recently signed a contract with a vendor who specializes in just those languages. So we understand the need. We're trying to meet those needs. And one of the things that we also want you to think about is that, and one of the things I want you to really know about the refugees is they are only given 3 months of government support. So you may see them for 3 months, and then they're going to fall off the face of the earth. At least for you, because for many of them, it is very hard for them to find jobs that have benefits. So then they can come back. So I say that because I want you to think about when you think about scheduling them out and they are a refugee, if you schedule them out farther than 90 days, you may never see them again because all of their federal benefits end after 90 days. So if they don't if they're not gainfully employed with benefits where they have health insurance, they may not ever come back to that actual appointment. The last thing I just want to focus on, because I'm just really want to be aware of time, is what's our role at BJC Diversity, Equity, Inclusion, and kind of what is the role I want to ask all of you to consider in this work. This is not your role, but this is one of our roles as BJC, and that's looking at Joint Commission's healthcare equity standards and how we have to do this. Some of the things we have already done, some of the things we are already in process of doing. I know some of the leaders in this room are very aware of some of this, and they may even know the people who have been designated as those leaders. Things we were also doing is we are also collecting data. We're collecting the data that helps us understand what are the social determinants of health that we face across the St. Louis region. Our partners at Missouri Hospital Association has an amazing dashboard that can show health outcomes across Missouri, across hospitals, across regions. And what I just want you to understand is that if those are things that you are interested in, we want to be able to have you look at it and understand it and see what are the roles that we can take to maybe address some of this, right? So as you can see, you can think about how many people are food insecure, kind of in at Barnes Jewish Hospital. How many people are socially isolated? I know that's one of the biggest research pieces right now are people as, death by loneliness, suicide by loneliness, or just health outcomes plummeting because they're socially isolated from community and from community support. And then I think those are the three, right? Food insecurity, financial strain. Oh, housing is the other one. And then I also know that I believe WashU and our community health improvement partners are actually working together for trying to do that better, of trying to uplift housing in our region, in our area, to try to give people that kind of housing assistance and housing support. We're also collecting it from a billing standpoint. Not sure how many of you are deeply interested in the billing data, but we do collect that as well. And then we also collect it from a healthcare equity data. Just one of the examples, we look at patient experience all the time across all of our departments. What we know is that patient experience differs drastically across race. That does not necessarily mean anything particular towards you. We just know that there is people of different racial groups do have different experiences from their own experience and how they feel they have been treated across our hospital and hospital system. Other ways you can see how this work kind of unfolds, right, from hospital A, B, and C, of how they're trying to address some of these barriers, how they're trying to work on some of this work. I'm just trying to get to the point where we can have questions and Q&A. This is what we ask you to consider, kind of the roles you have. As you can see, you don't see a role in, you don't see us say, eliminate healthcare disparities for us. You don't see us tell you to basically completely change how you do your work. All we're asking you to do is kind of think about what are the opportunities that you have to reduce and eliminate health and healthcare disparities. Simply, one of the things is just keeping it in mind that different community groups come with a lot of different experiences, maybe a lot of different hardships, and that they may need a different conversation from you than maybe the typical time. One of the constraints I know you always have is time. Right? Does anyone know, because I don't know this anymore, what is the average time a physician gets to spend with a single patient now? I don't think it's very long anymore. So you can imagine that's a huge constraint, because how many of you like know how many patients you have to see within a day, right? You just kind of know this, and then you break it down by like, well, I have this many hours, so that means it would be this many seconds or minutes I have with each patient. And how could I possibly, how do I spend more time with this patient knowing that that means I'm cutting time away from this other patient, right? So I know that the time constraint is there. The other thing that we want you to think about, and this is something that both Washington University and BJC offer, is we want you to just kind of walk through the idea of what biases you've learned. And biases is not bad, is what are the inclinations and what are the shortcuts that you've learned, and how does that help and potentially harm decision-making every once in a while. The other one is treat and communicate with individuals the way they want to be treated. Rich Leikwig, our president and CEO, always talks to us about the platinum rule of you treat people the way they want to be treated. Not the way we want to be treated, the way they want to be treated. Right? A patient asks you to use he, him pronouns, you use he, him pronouns. Simple way of conveying respect. Patient is illiterate in both languages that you want them to be semi-illiterate in, right? Like English and Spanish. That is a very common thing, is that you will use one of our interpreters, you will use video or phone or an in-person, and you think, man, I'm just gonna give them a Spanish translated document and it should be good to go. And you find out that they are both illiterate in English and Spanish, and all they can hear and all they understand is their language spoken orally. One of the opportunities we want to explore with the with either the Department of Medicine, Department of Surgery, any of those groups, is if they're willing to partner with us on a pilot where we will actually record some of that work you want people to be ready for, and actually record it on videos, and then share the videos via YouTube or Vimeo or something with your patients, so then you're not printing off like 50 sheets of paper. These are the things that we need you to understand when you go home, right? And they actually hear it in their own target language. And then they can even share it with their friends, right? So if it's something that's general that we want people to know, they can share with friends, or they can refer back to it time and time again. I also always want you to think about what are the other factors in someone's life and how it affects their potential health outcome, right? You think about, we think about the non-compliant person. There's probably very few people in this world who are non-compliant because they actually don't care about their health outcome. Many people are non-compliant because of those social determinants of health. They can't get here. They can't afford it. Or they're terrified. The other one is implement changes in your clinical spaces. This is not on you. This is me just asking people to think about what are the clinical practices and are there ways to make changes. So that is just understanding what are the emerging practices? What are the next practices that we could explore and try? And I have no idea why that just went out on me, but that's okay. Oh, there we go. And then finally, connect with the bigger picture of health equity, and that's supporting, whether that is if you want to get involved in the legal world, which I'm sure you're not allowed to, but if you want to, feel free to do so. Feel free to think about how legislation affects healthcare and things like that. Join boards, go to those big conferences and learn more and more on how we do things. And then finally, and this is just the one for leaders, I want you to support those who want to get more involved. And then if you are fellows or you are informal or semi-formal leaders in your group, support each other. One of the biggest things I think that diversity, equity, inclusion does not talk about as much as we should each and every day is at the end of the day, DEI work is about supporting one another and having the joy of connecting with each other and wanting to just be in community with people. A lot of it seems like we have to change this, and not do this, versus how do we do this together? And how do we make the experiences that we all have wanted, the experiences that everyone can access and be part of? And so with that, Q&A, but I also know that many of you were waiting for this one, so I'll put that one up so you can do that. But if there are any questions, why are they telling me I need to stand? Holy cow, I've been standing the whole time. But yeah, thank you.
Thank you, Chris, for that very nice overview of what BJC is doing in the DEI space, and particularly the actions at the end for each of us to think about of how we can move forward as a part of this work. So we do have time for questions, and thanks for the early participation. But any questions or comments?
Yeah. Mm-hmm. Mm-hmm. Yep. Yeah, absolutely. And thank you for that. And what I'm hopeful for is that I do believe more and more people are thinking about it that way. I think that more and more people are finding that are not only desiring to do that, but now we're finally finding that language to say it out loud again. And that we're all moving towards how do we focus on the outcome? And that is the primary focus. And how do we do it in a way that we're not indoctrinating, or we're not shaming, and we're not doing it certain ways, but we're actually trying to empower. And we're trying to center what's most important, and that is the outcome of people. Yeah. Mm-hmm. Yep. Mm-hmm. Yeah, that is a great question. I'll give you the easiest answer. So in kind of the general aspect, and I will say Washington University and BJC HealthCare, we are very different than most healthcare institutions you are probably aware of. We try to do in-person first. We are understanding that a person who speaks a different language than primarily the all English that we experience in a hospital, we know that connection of seeing a real human being hearing their own language actually helps increase health outcome and the willingness for someone to actually follow through with with the suggestions of their provider. From a refugee experience standpoint, what is very difficult is that most of the time the refugees coming in are unable to meet the assessment qualification of being both proficient in English and the language. So usually we have people who can speak Pashto all day, can speak Ukrainian all day, can speak Bosnian all day, but then it's, can you be the communication bridge between that patient to the physician? That part is usually where it falls down. So we're always a couple years behind and lag. However, the thought you bring forward is a very interesting conversation that I would love to bring forward to Ari Oberson, who is the CEO of International Institute, because one of the conversations I had with him recently is, what is the opportunity of healthcare for our new Americans? And if there is a way that we could help train some who are maybe slightly higher educated, right? People who may have had to flee, but are actually quite educated in their home country. Is there ways that we can start their careers off as interpreters? That would be a great thing. So yeah, absolutely. One of the hardest things though is one of the things that we do see is because you are a world-renowned health med group system and physician group, we get people from all over the world that is not the actual regional makeup of our teams, right? So you'll have someone who's like, I speak Maltese and I'm gonna get this really amazing surgery done by WashU. And we're like, there's not a single Maltese person in 400 miles of St. Louis. So that's kind of that's where we also can see some constraint is that if you get certain languages, we as a region just don't have them. We don't have a community of that grouping of peoples. But I take it very seriously, the want and desire for many of you to have that in-person interpreter.
I think we have time for one final question, Tom.
Mhm. Yep. Yes. Mhm. Absolutely. So you're already killing my 24, 25, 26 strategic plan for language access. So two things I know it interests WashU tremendously on both of them. One of the directions we are trying to push for from beyond just being the provider of choice, right? So just having interpreters is on the flip side of what does it look like to create language diversity inside of BJC HealthCare? So what we're doing, and we are going to do this, I promise you, it is on my to-do list in partnership with whatever department leaders want to be my pilot groups. One hand, we want to reward and allow our multilingual physicians to be multilingual, right? To let them be bilingual providers, right? All they have to do is pass an assessment. Can you do medicine in more than one language? And if you can, we want you to. We want you to have that actual connection with your patient that doesn't require an interpreter at all times, kind of doing it where I could physically tell my patient this information. That's one. The second one that you were talking about is one of the things that we're also looking to is how do we create language group in certain job roles? So if we have Bosnians who basically could be case managers, why aren't we just paying for their education to become case managers? And then we have Bosnian case managers. And then also think about when we think about patient access or scheduling, can we pilot an all Spanish scheduling team where those who speak Spanish just call in and say, hey, I need to change my appointment. I need to do all of this. And it's just all in Spanish. So what we're really thinking about is exactly that. How do we create that momentum of job accessibility that is for kind of all of our multilingual team members, but how does that also help our physician and clinical partners do their work better, right? Because I'm sure you can imagine from an endocrine standpoint, if you had the Bosnian case manager who was like, oh yeah, this entire group of people, you know how to talk to them, please just help them out. How much that would probably easy on the time you have to take talking about simple things and actually being able to provide that next level of care I know you want to be able to provide them. So those are two things we are very much committed to, and we hope that WashU at all times are going to be our faithful, willing, and I'd probably say progressively pushy partner for us to do it faster.
Okay. Well, thank you very much. And thank you all for attending.
Thank you.